All right, welcome to the guided heart dissection for ANP1 with Professor Jensen at Wells College. My name is Scarlett Lansky. I'm class of 23, biochemistry and molecular biology major, and I will be leading you through this guided dissection. So this dissection is going to be looking at not only the anatomy of the heart, but also some certain complications that can arise or medical emergencies that can arise with your cardiovascular system, in addition to the anatomy and physiology. So let's get started. As long as you have your notes, feel free to follow along. If you don't, that's okay. You might also want to watch this while you're dissecting too. It just might help you out. So let's get started. All right. The cardiovascular system is made up of three main components. It's kind of like your own internal plumbing system. And with any plumbing system, you have the pump, which in this case is your heart. You have the pipes in our bodies, it's our vasculature, all our arteries and our veins and everything else. And you also have the contents of those pipes in your plumbing system, which in this case would be your blood. And all of these things work together to deliver the oxygen and the endocrine factors and the nutrients that your body needs to stay alive. All your cells need every single one of those things, and without them, you'll die. So you gotta make sure you have those. Just a little bit of a word breakdown. When you hear cardiovascular, it sounds like a really big word, but just break it into little chunks. So cardio has everything to do with the heart. Vascular has to do with your vasculature, or in other words, all the little pipes that run throughout your body. So that's just what that means. So when you hear cardiovascular, think of having to do with the heart and the circuitry that runs through your body to deliver blood. All right, so let's take a little bit of a look of the anatomy through the direction of blood flow. Now, the heart, it receives blood from your body, which is called the systemic circuit. We'll talk about that more later. Through two really big veins. You have your superior vena cava, which would be this guy right here, and your inferior vena cava that comes up through the body like this, and it feeds into the right atrium. So let's look at our heart here. So your vena cavae are not on your heart. If you're dissecting with me, you're probably dissecting a sheep's heart. But you can almost detect where they would be if they hadn't had chopped them off. Up here is where the atrium would be, in this area sort of, and the vena cava would come through both top and bottom, from the superior part of your body to from the inferior part of your body to the atrium, and basically dump off the returning blood to your heart into there. That blood is deoxygenated because it's been through your body, your cells have taken up all the oxygen from it. You don't need anything else from it because it has nothing left to give. And it has some CO2 that you gotta get rid of too. So that's why it's coming back to the heart. So into the right atrium we go. And then the blood is going to go down to the right ventricle. And the right ventricle is a little bit bigger than the atrium. It's going to contract, and it's going to force that blood up into the pulmonary arteries. And the pulmonary arteries are going to take that deoxygenated blood, and they're going to travel it towards the lungs. When you hear pulmonary, I want you to think of lungs, because that's what pulmonary means. It has to do with the lungs. So the pulmonary arteries are taking that deoxygenated blood, traveling here and here, to the pulmonary circuit, lung circuit, where in the lungs, at the level of the alveoli and capillaries, it's going to take up more oxygen and get rid of all of that CO2 that it has taken from all your cells that are producing that as a product of cellular waste from respiration. Once that has happened in the pulmonary circuit, it's going to come back to the heart to be fed through the rest of the body. And it's going to do that through what is called the pulmonary veins. Pulmonary veins are right here and a little bit over here. There's some that come over there. And it's going to dump off into the left atrium. Now, let's just take a pause real quick. This is our right ventricle right here. Remember how I said that guy contracts? It's gonna contract up. Now, like I said, the vein isn't here, or the pulmonary artery, artery isn't here because they cut it off during harvest, but kind of see where it would be. That's where it would be contracted. Out to the lungs it goes. Then when it comes back, it's going to come back kind of like in this fashion and across here into your atria over here, your left atria. And that's through those pulmonary veins. Now, the pulmonary veins aren't really on there either, but this is kind of like a remnant of one that kind of got chopped in half. It's gonna come down through there and feed into the atria. The atria in the left side is now going to feed it to the atria, or the ventricle on the left side. So it's going to push that blood again down to the left ventricle, and the left ventricle, which is supramuscular, is going to do one huge contraction and send it up into the aorta, where it then can be distributed into the body. So if you're following along with your heart, here's our really big and muscular left ventricle. It's going to contract up. This would be the aorta. Again, it's been chopped in half into the aorta, where it can be distributed to the top and the bottom of the body. That aorta also is called descending and ascending, depending on whether or not you're going up or going down. So that would be your number 13. Or number 14, my bad. All right. So something I want you to think about when you're looking at the heart, or for anybody who's going into medical, you're gonna notice that the sides are reversed, right? I said that the left side was over here and the right side was over here. And I'm not wrong. Because when you were going into medical and you were describing a patient's injuries or a patient's ailment, you were going to describe the location of those injuries as they would be viewed from the patient. So if I'm your patient and you're looking at my heart, which is in this similar fashion, right here, situating a little bit slanted towards my left side, I would be looking at my heart, and that would be on the left side of my body, all right? So it's not how you view it, it's how your patient would view it, and that's how you would describe that. Because I promise you, if you get into the medical field and you switch those up, the doctors are gonna look at you like you don't know what you're saying. So that is why it is referred to kind of backwards as to what we would say. But that's standard all over the globe, so, you know, don't bite the messenger. Some helpful vocabulary with this. I mentioned atria and ventricle. Atria just means upper chamber. So if you can't think of what it is on the test, just remember upper chamber, atria. With the stratum atrium, it's that upper atria that we have in our building that is, above everything else. Ventricle comes from a Latin term called venter, which means belly. So your ventricles are in the belly of your heart, the bottom of your heart. And like I said, with pulmonary, that just means anything to do with the lungs. Your pulmonary circuit, your systemic circuit, both are just describing the circuits and their location in the body. All right, now that we've gone through the path of blood flow, let's talk about it. So obviously, this is a one-way street, okay? The blood does not get pumped back and forth through these places because that would be really, really bad for your blood flow. So to ensure that the blood kind of keeps moving the way it's supposed to, there are 4 main valves in the heart. Remember how there are like 4 main chambers that could help you out there. So they kind of act like floodgates to prevent any sort of backflow that you might get when you're constricting. Because remember, there's a little bit of force there, it might splash up and down. Well, those valves say nay, nay. So when you are going from the right atria to the left, or to the right ventricle, okay? You're going to go through this valve right here. It's kind of stringy, okay? And that valve is called the tricuspid valve. And it's called tricuspid because it has 3 little cusps that kind of make, here, I'll point it out to you on your sheet. 3 little cusps, 3 little doors, and that's why it's called the tricuspid valve. And as you go to the pulmonary artery from the right ventricle, you're going to go through the pulmonary valve. Pulmonary artery, pulmonary valve. There you go. The pulmonary valve actually only has it has 3 cusps as well. So you can think of anything on that side as having the 3 cusps to prevent that backflow. When you go to the lungs and you come back and you have this nice new oxygenated blood that you're going to feed back into the left atrium, it's going to go from the left atrium to the left ventricle, which is what we covered before. And when you do that, again, these stringy little things right here, that's the valve, you're going to be passing through what is called the mitral valve. It is a 2-cusp valve, which is significant because it's actually a little bit more efficient at preventing the backflow than the tricuspid valves. And once you are in the left atrium or in the left ventricle and you want to go into the aorta for distribution around the body, you're going to go through the aortic valve. Aorta, aortic valve. They're just describing their locations at this point, the names. So nothing else, just think of the location and then you might be able to guess the name. And everything on that side is a actually that one is the valve right here. That's a tricuspid valve. My apologies. So yeah, everything over here, the valves over here, 3 cusps. This guy to this guy, just 2. All right, so the heart's pumping. It's getting all that blood throughout your body. That's great. But how does the blood even move through these valves in the first place? Well, the heart is entirely electric, okay? It's super great at conducting an electrical system that controls your heart rate and stimulates all of those chambers in the heart to constrict and contract, which moves your blood. So the way it does that is it's not just some random shock going through your entire heart. It's coordinated to make sure that the blood is being pumped in the most efficient way possible. So it's to coordinate that, there are a series of nodes that are located within the heart, and nodes are just like a collection of cells, really, that connect that. So the first node that starts this whole process for each beat is the SA node. And the SA node starts a little bit somewhere in the atria, and that guy, he creates his electrical impulse, and it stimulates atrial contraction all around. So that electrical impulse is going to travel kind of like that, and it's going to tell the atria, hey, it's time to constrict. And once that current kind of reaches this general vicinity, it's gonna hit the node that's right here, which is our atrioventricular node, okay? And he's gonna sit either in here, someplace. This is in front of where he might be sitting, so, you know, just don't take it for face value as this is exactly where the node is, because, you know, the heart is, you could only see it from so many sides at once. So atrioventricular node sits somewhere here. He's going to also receive that electrical impulse, and he's going to take it and he's going to send it down through this, which is called the septum, this kind of big nasty thing here. To remember septum, people get septum piercings all the time, and that's that that little flap that divides your nose. Septum just means like thing that divides, so that's how you remember that. He's going to take that electrical impulse and he's going to send it to the bundle of His. Now again, these things are just kind of telling you in their name where they are. Atrioventricular node, atrium, ventricular. It's right in between the atrium and the ventricle. There you go. The bundle of His is in this general vicinity, and again, it's just a highway for this electrical impulse to travel down, and he's gonna travel down through here until he hits the bundle branches. So once he gets to around here, those nerves are gonna start to spread onto each of the ventricles, and that is where it's going to stimulate the contraction of the ventricle to begin with. That's where it starts dividing into each of the ventricles. And on the smaller level, once it's really in each of the ventricles, it's gonna hit the Purkinje fibers. And these fibers are very small, they're running in here, and once you hit those, then it's game time for ventricular contraction. And it's also good to know that there are papillary muscles that kind of hold these valves, right? You see like these things right here. That electrical pulse that is being fed through those nodes is also hitting those papillary muscles and saying, hey buddy, close your valve so that we don't have any backflow into the incorrect chamber. So that's what's happening there, and that's how it moves the blood all at once. Now it's important to know that when it contracts, when the impulse starts up here, it first starts in the tip and then spreads, so it's kind of like that contraction. And then once it's down here, it doesn't just contract up here either, it starts again around the bottom of the ventricles, squeezing the blood kind of upward so that nothing is left behind to get trapped, and it's all being forced into the direction it's supposed to go in the most efficient way. The pulse of electricity that it's sending, it's literally just a wave of like depolarization. You know how on your cells you have membranes? Those membranes are polarized or depolarized. In this case, it's just depolarizing the membranes, which actually stimulates the muscles to contract. So by changing that electrochemical potential on those membranes, you're causing a chemical change that just says to the muscle, hey, it's time to contract now, based on our electrical potential. If you take any sort of Burwell class, she could probably go into that further. And also any like Bailey or a Bailey class, he's very good about explaining action potentials for chemical gradients. And that's what that is. But that's all you really need to know for AMP. All right, so let's talk about some medical tools you can use for cardiac monitoring. Healthcare providers, and I'm talking doctors, nurses, your paramedics and your EMTs on the rigs, pretty much anybody who practices medicine, can visualize the contractions and the electrical chemical potential, for that matter, of the heart with something called an ECG, or also referred to as an EKG, which is it's kind of like this computer thing that you hook up to your body with electrodes placed at certain like locations on the body, and it just gives you like this really cool picture of what the heart is doing. So ECG stands for electrocardiogram. That's what that does. Electricity, cardio, heart, gram, picture. Electricity, heart picture. There you go. The electrodes themselves that they hook up to you, those are called leads. And you might hear them referred to as a 3 lead, a 12 lead, maybe even more. Those just denote like how many leads are being used for a particular picture. Your provider may use one, they might use the other, they might use both. That's completely up to them. But what it does, it just gives us a really good look at what the heart is doing with that electrochemical potential, with that beating. And if you look at your diagram, you're going to see all the locations of those leads. So if you're me and you're an EMT, I would most likely set this up, and then I would have the paramedic interpret this, or I would send it to the hospital so they could interpret it. I myself can't interpret this, but I can put the leads on. And the leads that you're gonna see are green, black, white, and red. And you get a better picture on your diagram, but I could put them here, one here, like in this little area, or on my ankles. You know, that can get me like this nice good field of vision for the heart. I could also put them here, right under your clavicles, and kind of like right here, just above your hips, just above your iliac crest. Or, you know, if I was really fancy, I could put them here. And this is something that you'll see the paramedics doing most, is putting them here, because it gets you a little bit better picture. That is entirely up to your provider as to what they want to do, but it all gives you a way of looking at the heart. That would be your 3 lead. Your 12 lead would incorporate a few more leads that just give you a little bit bigger picture. So when I'm putting a 12 lead on someone, this is how I put it on. First, I try to find the clavicle. Let's see our friend here. Okay. First, I try to find the clavicle, which is this bone that sits right here, your neck bone, some people call it. And then what I'm going to do is I'm going to feel for that space in here. It's called your intercostal space. Talking up here is really drying my throat out. Okay. Your intercostal space. And then I'm going to find the bone. I'm going to go 1. I'm going to find the next space, put my finger there. Find another bone, 2. Next space, put my finger there. Another bone, 3. Next space, put my finger there. Another bone, 4. Next space is the space that I want to put the electrode in, which would be right here. And on this guy, it would be probably about right here-ish. Yeah, he's a little small. But for reference, that would be right along the nipple line, or what is commonly referred to as the mammillary line in medical terms. So your sternum is right here, this bone right here. I am going to want to put that first lead on the side of the sternum. I'm going to put it on the right side in between those spaces. And then when I put on the second lead, I'm going to go directly across into the other space, and that's where the second lead goes. So like right here, if you're following along on yourself, that's where you would put it. There are more leads to put on. So what I'm going to want to do is, now that I found that place for the first lead and the second lead, I'm going to go on the left side. I'm going to go below, find the 5th rib, right? So I'm on the 4th rib, I'm in the space, and the 5th rib is right there, right below that space. And I'm going to put it kind of right, like, you know, right under the, right kind of under the nipple. So at this point, it looks kind of diagonal. If it was right here, it'd be right here. Okay. Now that I've established that, I'm gonna go back and I'm gonna put the next lead on, and I'm gonna put him like right here to get like a little curve. So 1, 2, 3, 4. Now I gotta put well, now I gotta put 5, and he goes between, now that I found this guy, right? So I put him there, I put this guy there, and then the next lead that I'm gonna put on, I'm gonna put it on kind of under the armpit, along the same sort of line, again with a little bit of a curve right here. And then I'm going to take my final lead and I'm going to put it in the middle, so that I have kind of like an underwire swoops under and cups, that nice little sickle shape, to get the cardiac monitoring. Now you'll notice it's on the left side. What's on the left side? Your heart. Your heart is faced like that, you know, so I'm putting it on the side. That's going to give me the best chance of looking at your heart and how it's doing. If you're interested in the views, I've listed for you on your note sheet what each one of those leads can show you. And my question for you is, have you ever taken your blood pressure or taken the blood pressure of someone else? A blood pressure cuff is called a sphygmometer. It would be your 22. And it helps you measure blood pressure and assess the healthiness of the heart with two numbers. The first number that it records is called your systole, or your systolic. That is the pressure of your heart on your arteries and your on your vessels, which mostly this one, when your heart is contracted. So when your heart is like this and it squirts out all that blood, it measures the pressure of that squirt. Your aorta is super elastic. So when it has that big, nice, powerful squirt, the aorta isn't just gonna burst. It's gonna be like, whoop, whoop, to accommodate that pressure. And that pressure eventually evens out. But that's what the first number is recorded. And it's definitely higher than the second one. It should be higher than the second one. If it's not, you have a serious problem. The second number is called your diastole, or your diastolic. And that is the minimum pressure that is exerted on your vessels when your heart relaxes. So, you know, we got the heart constricted, we have that nice big gush of pressure on our aorta. Now the heart has to relax to allow for blood refill so that it can go into the next contraction. And when that heart is relaxed, there's still a pressure that's maintained on your vessels because there's still fluid in there. So physics says that there's still going to be pressure exerted, or else you would have vein collapse, which would not be good. So you have that pressure in there, and that's the minimum pressure that you're ever going to have at one time. So that's what your blood pressure is measuring anytime somebody takes your blood pressure. An adult blood pressure is usually 120 over 80, 120 systolic, 80 diastolic. That's normal, but also if that's not your blood pressure, don't freak out. You know, people have different normals. So when I assess someone, I'm looking for not what your blood pressure is, but like, for instance, what's the difference in those two numbers? Or is one of those numbers really, really low or really, really high? That can give me an indication of why you called or what's happening to you that could, be giving you these issues, which we'll go on to later when we get onto another sort of emergency. All right, so let's talk about the cardiac membranes. Let's find out our way here. Okay. The heart has membranes and different layers that do different things. And it's important because they either protect the heart, or they allow the heart to beat, or they keep the blood from dripping out of the heart. So they're pretty important. They do some really fascinating things. And the first one that we're going to talk about is the membrane that surrounds the heart. It's called the pericardium, or the pericardial sac. Peri meaning next to, cardium meaning heart, next to the heart. That pericardium that is around your heart, if you're dissecting, it has two different layers. It has a fibrous pericardium and a serous pericardium. Let's talk about the fibrous first.
So the fibrous is really dense. It's connective tissue, basically, and it keeps your heart where it is in the chest. So could you imagine your heart's sitting right there, and you're running around? If you didn't have that fibrous pericardium, and you're an athlete, that would be pretty bad. Your heart's getting jostled around in there. You might hurt your heart. You could accidentally tear one of the vessels if you didn't keep it where it was. So that's what that guy does. Let's talk about the serous pericardium. The serous pericardium also has two different layers. It has the parietal and the visceral pericardium. Now, parietal means kind of like the outward layer. Visceral means covering the organs. So the parietal is fused to the fibrous pericardium, and the visceral is fused to the heart wall. In between the parietal and the visceral is a nice little cavity that has serous fluid in it. And that is important because if you've talked about the lungs already, you'll notice that the lungs also have a parietal and a visceral pleura. Physics says that when two things are rubbing together, it creates friction, and it keeps them from wanting to do any sort of movement. So could you imagine if there was friction going on in your lungs? It would be very hard for you to breathe. So what the parietal and the visceral layers do is one attaches to your lungs, one attaches to your rib cage, and it has that nice little fluid in it that allows for that smooth gliding so that your lungs can expand and contract. The parietal and the visceral pericardium with that cavity does the same thing. There's a little bit of serous fluid in there that allows for your heart to do a little bit of movement without causing friction and heating up, without tearing itself, without, being constricted so much that it can't pump. That would be horrible if you couldn't pump your blood. So that's what that does. The parietal and visceral pericardium can also be kind of referred to as like the epicardium. Epi just means above the heart. The membrane is kind of outside of the heart, so that makes sense. When you have an issue with these layers, you might, if you're in the medical field, come across something called a cardiac tamponade. Now, let me see if I can show you on your heart where this layer is. I'll talk about it in a moment. So, kind of notice it's a little bit dark, but there's this dark layer. And then there's this like fleshy layer right there. It's, just this glistening layer that's on the outside. It can kind of poke and pull up and maybe even rip a little bit. That's your pleura, your pericardium. Okay. If you're a medical professional, like I said, you might come across something called cardiac tamponade. A classic sign of cardiac tamponade is with that blood pressure. And I'll tell you why. When the heart suffers a penetrating trauma that bursts through those cardiac membranes, remember there was fluid in there that was supposed to do that gliding and keep that friction to a minimum. But now blood is trying to take its space. So imagine the constricting of those ventricles, and imagine every time
that ventricle is constricting and sending blood to the rest of the body, it's also sending a little bit of blood into that space. That space is going to get a little bit more blood each time. And at first, your pericardium is going to be able to expand a little bit to accommodate this, but it can only expand so much. And if this keeps going on longer, it can lead to death, because the fluid that is not supposed to be in there, that blood, is going to compact, and it's also going to push inward on the chambers of the heart. So kind of like an anaconda squeezes its prey, the fluid is going to do the same thing. With each constriction and relaxing, a little bit more fluid is going to come in. It's going to go surround the heart, and it's going to make it that much harder just to open up and let that refill into the chambers again, until the ventricles will no longer be able to open up, because the constriction is too much and the pressure is too much that it's kind of like asphyxiated the heart, just like an anaconda would its prey. An anaconda suffocates you by every time you exhale, getting a little tighter around your lungs, until the point where you can't inhale anymore. So that's what's happening in cardiac tamponade. As I was saying with the blood pressure earlier, remember how you have your systole and your diastole? Well, with cardiac tamponade, when your constrictions become weaker, your systole is going to become weaker. Your systole is going to go down. Remember, your systole is that push, that pressure from that push of blood. If you're not pushing out as much blood, or if you're not pushing out the same pressure because you're being crushed, that poor ventricle, your systole is not going to be as strong. So in these patients, you can often tell it's a cardiac tamponade if you're reevaluating their blood pressure every few minutes, and their blood pressure goes from like 120 over 80 to 115 over 80 to 110 over 80. That narrowing of the blood pressure is really bad, and you need to go to the hospital right now. That is an emergency. It will get to the point where your heart can no longer beat. And that's not fun. That's cardiac arrest, that's death. So keep that in mind if you're going into the medical field. That is something you might have to deal with. All right, let's talk about that myocardium just a little bit more. Myo means muscle. That is exactly what that layer is. That big fat layer in between here. I kind of like to think of it as the meat of the heart. That is muscle. That is extremely strong. It does a lot of cool things. And it's made of collagenous fibers that allow for that contraction on the cellular level. When you're thinking about medical terminology, you might come across a term called automaticity. The heart's ability to spontaneously generate its own membrane action potentials is this automaticity. The heart can beat and beat and beat and beat without an external stimulus for as long as it can, until it runs out of energy. So that's important because this myocardium kind of operates on that principle. You might notice that the myocardium on the ventricle on the left is significantly buffer than the myocardium on the right. Can you think of why that might be? I'll give you a second. Okay, I'll tell you. Remember how I was talking about your pulmonary and your systemic circuit? Which one is longer? Which one is shorter? Which one is going to need more force and which one is going to need less force? The answer is the right ventricle is thinner because it does not need to pump at such a high force to go to the lungs. Your heart's right here, your lungs are right here. Could you imagine if it was just full send? Okay, you know how you get your oxygen on the cellular level? It's through those little alveoli and those capillaries that are all interconnected within your lungs. If you were going full send at the level and pressure of the left ventricle, you would blow those little capillaries up, you would blow those little alveoli up, and then you can't breathe, which is why that's not a thing. So this does not need to go full send. It's going to the lungs, just needs a little bit of pressure to get it into the tubes and get it going, you know? This guy never skips leg day because he's got to go to the legs. He's got to go everywhere else to get all that blood throughout the body, to get you all that perfusion everywhere else you need to go. The left ventricle pumps to your entire body, and for that reason, it needs to be super strong. If it wasn't super strong and it had like the same sort of buffness as your right ventricle, your perfusion would not be great. You know, your pressure goes dramatically down as you go down, you know, because gravity. When it comes back up, the pressure is already it's less than half of what it was. The only thing really keeping it up and keeping it coming back to your heart is a series of valves that are in your veins. So this has to really work hard to make sure that the blood comes back. That is why it is so buff compared to the right ventricle.
If you are an athlete and you do a lot of cardio, I like to run, I'm a soccer player, you might have a thicker left ventricle. And that is cool because it does two things for you. It can lower your heart rate and also can increase your stroke volume. So if you have a stronger left ventricle, it can pump with much more pressure. It pumps the same amount no matter how thick it is on either side of blood with each pump, but the pressure is significantly more. And you don't need to beat as often because your blood is going further with each pump than it would be if you were a couch potato. So this guy could take a chill pill a little bit. He can pump and do his thing, but he doesn't need to go as much. So that's why your heart rate goes down if you're an athlete. That volume of blood that you're pushing is called stroke volume. And that can go down as well if you're an athlete. So, I mean, get out there, do your cardio. It's good for you. Let's talk about that endocardium. Endo means inner. The endocardium is the innermost layer of the chambers of the heart, and it's also inside most vessels. The endocardium is cool because it plays a role in muscle contraction and cell growth. It's made of simple squamous epithelium. It's literally just a layer of cells. Okay, it's just a layer that sits there and prevents any of the blood from like leaking into places it's not supposed to go. It is made of those endothelial cells, so that's your number 29 if you're following on the note sheet. And that's what it does. So these membranes all have kind of specialized roles. Some are thicker, some are thinner. They all do something important. Now let's talk about your vasculature. So vasculature, vessels, your pipes, this is what these things are. So you might be like, arteries, veins, what's the difference? Well, arteries, remember away. Arteries take blood away from the heart.
veins take blood back to the heart. So that's why you have your vena, your veins that feed back into the atrium. That's why you have your pulmonary artery, which is taking the blood from the heart to the lungs. That's why you have your pulmonary veins, which taking the blood from the lungs back to the atria. And then your aorta, which is just a really, really big artery that sits like right here. So that's some terminology for you. If you hear the terms venule or arterial, or maybe even a pronunciation difference of those are just smaller arteries and veins. If you hear the term capillaries, those are the smallest vessels that you have. They're typically like 1 cell thick. And those are the site of the diffusion and the gas exchange that connects they connect the venules to the arterioles. So when you're on the capillary level, it's very small so that it can allow for that diffusion across the cell membranes of your body. When you're in the lungs, the alveoli, where those air sacs that kind of fill up with air from your lungs, they're covered in capillaries. The capillaries can then do their business and be like, hey, here's the blood, you give me the oxygen, I'll give you the carbon dioxide. Things work out. So that's what they do. Vasculature emergencies. You can have 2 very similar types of vascular emergencies that deal with kind of the obstruction of these pipes. Remember, these pipes transfer the blood. If you're obstructing them, you're obstructing not only the blood, but the oxygen and the nutrients that are coming with the blood. And if you're on your way back to the heart, this heart needs so much oxygen to do what it does. It's not happy, and cells are gonna rapidly start to die after you cut off its oxygen. So let's talk about 2 emergencies that you might encounter as a healthcare provider. And the first one is being angina. When you have the deposit of cholesterol and calcium and other nasty little things that are in your blood that kind of just build up in your circuitry, it's called arteriosclerosis. Ugh, that pronunciation is bad. That plaque then kind of partially blocks the vessel and decreases the amount of blood that's getting to go through. This also decreases, like I said before, that oxygen delivery. This angina is only the partial blockage. It is extremely painful for the person who is suffering from it because, like I said before, the heart cells really need the oxygen and they are going to die so quickly without that. It's a excruciating pain. People who have this are probably telling you that it's crushing, it feels horrible, it feels like a stabbing, you know. That's what's happening in angina. For these people, if you're a healthcare provider like an EMT, aspirin can help. Aspirin helps, it's an antiplatelet, so it actually does thin the blood a little bit so that it can go through a little bit better and deliver the oxygen a little bit quicker. And that's a nice stabilizer to get you to the hospital so that you can deal with this in the ER. The next one that is also, it's similar to angina, but it's worse. It's a heart attack. The heart attack is called, in medical terms, a myocardial infarction. Myo meaning muscle, cardio, heart, infarction, an infringement or a blockage. You're blocking the access to certain things that are needed by these muscle heart cells. And that heart attack, the myocardial infarction, like I said before, it's the complete blockage.
and total obstruction of oxygen delivery to the heart. It is also extremely painful.
And also worse, people who have a history of this will likely be taking some sort of vasodilator or drug like nitroglycerin. It's a sublingual medication that helps with any episode you might have that's cardiac related with chest pain. But the important thing is, once you take that, you gotta go to the hospital. I mean, it's just like a Band-Aid on a gushing wound that's only gonna help you for so long. So, if you know anybody who suffers from this, maybe ask them, do you take nitro? Do you take anything to help this? So, yeah. Another vasculature emergency that you might come across is something that happens after a heart attack. It's called CHF, congestive heart failure. And if you are lucky enough to survive a heart attack, you're probably at a little bit higher risk for this. Here's why. Remember how I told you in a heart attack, you are totally cutting off the oxygen supply. Your heart is not getting oxygen, okay? Heart cells are gonna rapidly start to die. And if you fix that, great, kudos to you. But you still have a little bit to deal with because there are some cells that are dead. Those cells that are dead, they scar over, and now they become a burden to the remaining heart cells that are left. And your heart has to work even harder now to do what it was doing before, to pump all that blood through your body. So your heart is gonna become worn out. It's gonna get tired, and it's gonna become a little bit less good at pumping that blood through. With a congestive heart failure, it's so burdened that sometimes it leaves a little bit of blood left back in each of the chambers and doesn't squirt it all out. And if that continues to happen, it just builds up and it builds up. Congestive heart failure, congestion, the heart is failing because it's congested with blood. And what really gets people, or what is a good sign of this, is remember where all this kind of goes? It goes to the lungs, right? You have those pulmonary arteries that are taking the blood that was supposed to be in the left or the right ventricle to the lungs. When that gets backed up, your lungs get backed up. Your alveoli become kind of saturated with all this backed up blood, and you can burst the capillaries. You can cause leaking into the alveoli. And something that is a telltale sign of congestive heart failure out in the field is pink, frothy sputum. When you spit, that's sputum, and because of the bursting and the lacerations that are being caused towards these really small veins or really small vessels that are in your lungs, it's getting mixed in with your air, and you know, there it is. It's up there. That's a sign of congestive heart failure. That's what that is. And that's not fun. If your heart backs up and you're unable to pump efficiently, you know, it's the same thing as what we've been talking about. You're not gonna be able to deliver the oxygen and the nutrients that are needed throughout your body. So that's that. All right. Now we talked about the pump, we talked about the vessels. Let's talk about your blood. Your blood is considered a connective tissue, and most organisms have blood or a form of blood, but not all do. If you're a SpongeBob fan, sea sponges do not have any form of blood. They just vibe in their own life without their blood, which is cool. I don't know how they do it, but
not the focus of the lecture today. This blood delivers the oxygen that you need to your cells, and also the nutrients, and also helps clear up all the waste that are left as a product of cellular respiration or cellular processes. Vertebrates have a wonderful little molecule in your blood called heme or hemoglobin. If you ever watch a vampire movie, I'm pretty sure they're like, I'm gonna drink your hemoglobin. It's just blood. They're really referring to this molecule right here. Hold on, I'll show you. This molecule right here. That's heme. And that heme is important because it takes up the oxygen in the first place. If you take bio and organic with Bailey, you'll learn all about that and all about the biochemistry of that specific molecule and how it actually does take up the oxygen. But all you need to know for now is that in a bigger molecule that is comprised of 4 hemes, one heme will be in contact with oxygen and it'll be like, I guess I'll pick this up. Heme has an iron center that has a +2 charge. What do we know about oxygen? It's a greedy jerk. A greedy jerk that just so happens to want 2 more electrons to fill its valence shell. It's got a negative charge, right? So it sees this +2 and it's like, okay, I'm just gonna attach right onto that. That changes the biochemistry of that entire molecule and actually makes his neighboring heme more likely to pick up an oxygen. So his friend over here is like, my buddy's got an oxygen, I think I want one too. And then another heme that's in the back is like, oh my God, I want one too, don't leave me out. And then the 4th heme is like, all of my friends have oxygens, I want one too. So within that molecule it can transport 4 oxygens. That's really all you need to know, that the affinity increases as you continue to bond to oxygen. And fun fact, when you're gestating, when you are pregnant and you have baby in your uterus, okay, your baby's hemoglobin is actually at a little bit higher of an affinity towards this binding of oxygen than the mom's hemoglobin. And that's important because mom's hemoglobin really has no incentive to give baby the oxygen that is supposed to be for mom, right? Why would it do that? It has no reason to do that. So baby's hemoglobin is like, I just want a little bit more than you do. And baby only has like a couple 100 milliliters of blood, so it's not a problem. Mom has liters, a lot of liters. So babies takes a couple oxygens when the blood is in the umbilical cord and the mom's and baby's blood are passing by each other. Takes a little bit of the oxygen to feed baby that oxygen, or else baby would never get oxygen. Baby would die, there would be no reproduction of the species whatsoever. So fun fact, just a little tidbit. There are several parts to the blood, okay? There are red blood cells, also known as erythrocytes. They have that heme molecule in them that grabs onto the O2, and they are like a taxi that transports it to the cells. They do not live very long, only for a couple months, because they do not have a nucleus, at least in vertebrates, in us humans. Birds have nucleated red blood cells, so they can do some cellular reproduction. Humans do not have the red blood cells nucleus, so our blood cells are made in our bone and marrow, our red blood cells. They can't reproduce on their own. If you are a female, 41% of your blood is red blood cells. If you're a male, 45% of blood in males is red blood cells. So not a huge difference, but a little bit, you know. And you can think of that difference as kind of like a physiological thing. Men typically have a little bit more muscle mass. So the more myocytes you have, the more oxygen is going to be demanded. So you might have a little bit more red blood cells to accommodate that. This is just the average. There are absolutely women who have more red blood cell count and men who have way less. I mean, bodybuilders, you can increase your red blood cell count physiologically if you decide that you want to get buff and get those gains. You also have white blood cells. These are called leukocytes. You can remember that because if you ever heard of the term leukemia, it's a cancer of the white blood cells, which leads to people getting sick. And that's important because the white blood cells, they help fight infection, both internal and external. They help kill cancer and viral cells. Cancer's pretty common. And usually those rogue cells that divide without being checked by the cellular kind of Cambrian processes that your cell has, usually that gets caught by the red blood cell or the white blood cells. And, you know, cancer is scary, but it definitely happens more than we know it. It's just our blood cells are taking care of it. And viral cells, if you have a bacteria that comes in, decides it wants to make a home out of your body, your white blood cells are going to recognize that and be like, you don't belong here. Goodbye. And take care of them for you. These white blood cells, there's different types. You have two major categories. You have granulocytes and you have mono or lymphocytes. And they all do different things, which I'm not gonna quite get into now. You have platelets, which are also part of your blood. They're really small nucleated cells that help like start the clotting process. They're also colorless and disc-shaped, not, okay, they're disc-shaped. To give you like an indication of size, if the red blood cell was like a cookie, like a chocolate chip cookie, a white blood cell, or the platelet would probably be like a chip. The red blood cell is really a lot bigger than the chip. So there's also another thing called plasma. That is the transportation medium that contains fat and other things like corpuscles. It's colorless. If you're on the rig, the ambulance, the boo-boo bus, paramedics will often start IVs, and most of the time they don't actually do straight blood. Blood's hard to get a hold of. It's also not quite as valuable. Plasma's where it's at. Plasma's usually what they'll use if they're not using saline. If somebody is in major trauma and lost a lot of blood, we're probably going to give them plasma en route to the hospital. So that just is an indication of what's important. How much blood do you have? Well, if you're taking this course, I'm probably going to assume that you're an adult. So adults have, in general, 5 to 6 liters. An adult female, probably 4 to 5, just because of size difference. An adult male, 5 to 6. The bigger you are, the more blood you need. Blah, 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 blah. If you're a child, you probably have about 3 liters. An infant, like a newborn, a neonate, okay, fresh out the womb, 300 milliliters. Not a lot. When you are pregnant, your blood volume actually can increase up to 50%. To accommodate, you know, you're getting big. You got a lot of new vessels to go around, a lot of new cells to feed, and a lot of stuff to accommodate when you're growing a human inside you. So that's a thing. And that is why when baby is being born, it's super important
to know what you're doing when you are cutting the cord, because cutting it in a incorrect place can cause rapid and even fatal blood loss in both mom or baby. When you're cutting the cord, they usually do it 8 to 10 inches from baby. So like baby's here, cord's here, 8 to 10 inches. Yeah, probably right there. Clamp it there, and then another 3 inches up, clamp it there, and then cut in the middle. And that gives both the best chance of like not bleeding out to death. But just a little bit of real world for you. The temperature of your blood is also, interestingly enough, 1 degree higher than the temperature of your body. And that is because of friction. Your blood is in there, zooming around in little tiny balls, and it's rubbing on those vessels. It's friction. Physics, you know? That's just what happens. A little bit higher than the core of your body, but that's okay. I mean, it helps keep you warm, so whatever. If your blood is oxygenated, it's typically going to be lighter in color. If your blood is deoxygenated, it's typically going to be darker in color. When I was talking about like humans have that heme that helps us get the oxygen, there are other animals that have other sorts of molecules that transport their oxygen. There's hemocyanin, other molecules that make your blood different colors. You can have like purple or blue. You ever seen a horseshoe crab? The molecule that they have, I believe it's hemocyanin, don't quote me on that. They have blue blood. So, I mean, in humans typically, the darker and the lighter, you know, I don't know what it looks like, deoxygenated blood in horseshoe crab, but you know, if you want to look that up, go knock yourself out. All right, let's talk about some CPR. So, I don't want to do this because CPR doesn't have a huge success rate. If it's done correctly, everything is perfect. Maybe about a 30% chance. It's scary. It's scary to do this, but it can help. It really can. And there's a physiology and a science to it behind it. So when you are doing CPR, in the event of a cardiac arrest, it's when your heart is not doing what it's supposed to do. If your heart, like, cardiac arrest, like, no pulse, you're not getting a pulse, the heart might be beating just a little bit, but it helps kind of, it's not, CPR, cardiopulmonary resuscitation, is not meant to restart the heart. It's meant to keep the heart alive enough to get to the hospital. When you are doing it, you're gonna, again, find that mammillary line in the adult. You're gonna interlace your hands like this, and take that heel and put it in between that mammillary line, in between the nipples on the sternum. And for an adult, you're gonna compress at a depth of 2 to 2.4 inches. That's pretty deep, but you gotta think, the rib cage is really strong. You gotta compress hard enough to get through that rib cage and make an impact on the heart. So the science behind the compressions is that the compressions aid in squeezing out that blood out of the ventricles into the body. It just pumps the heart a little bit so that the blood can go and the blood can get the oxygen to the rest of the body like it's supposed to. Because if the blood's stagnant, no oxygen delivery. Not good. Bad news bears. So that's what CPR does. It can be done with or without a AED, which is called an automated external defibrillator.
it's a device that delivers a shock to help reestablish the heart's normal rhythm. So if the heart has stopped beating completely, our AED won't help. It's possible for it to come back. It really is. But that's not the goal of the AED. The goal of the AED is to just reset the rhythm that is not beating correctly to the rhythm that's supposed to be. So examples of cardiac arrhythmias, you can have ventricular fibrillation, VFib. That's when your ventricle is kind of like quivering. That's not normal. Your ventricle is supposed to go contract, release, contract, release. If it's doing that fibrillation, obviously good volume not being pumped out of there. At least it's moving though. So you have a chance with the AED. There's also VTAC, ventricular tachycardia. Really fast, really fast, not good. Also life-threatening. The AED, if you place the pads here, turn it on while you're doing CPR, it can help analyze that rhythm and deliver a shock to kind of get it straightened up and doing what it's supposed to again. You know, if your heart's acting a fool, the AED is like the mom with the chancla going, get back to doing what you're supposed to do. So that's what an AED does. When you do the CPR and the AED, your compressions are supposed to be at a rate of 100 to 120. If you ever heard the song Staying Alive, or there's another one out there, it has a good metronome for those compressions, and that's just because the heart in a normal adult beats around 100 beats per minute anyways, so you want to keep that consistent even if they're in cardiac arrest, because that's what's going to get you that adequate perfusion. If you're a medical provider like an EMT or CFR paramedic, your CPR is probably going to include ventilations as well. When you are pressing, you're doing, for an adult CPR, 30 compressions to 2 ventilations. And it's really important to not lollygag in between those, because once you stop compressions, you stopped the flow of the heart, and it takes a few compressions to get the flow going again. But if you do really accurate CPR, it gives this person a wonderful chance of making it out. The first thing though is to always remember, the first thing you do if you ever come across a cardiac arrest is to call 911. And if a provider is there, starting CPR, they might ask you to go get an AED. And the wonderful thing is, if you live in New York State, there are AEDs like almost everywhere now. There was a public initiative to get an AED in public spaces everywhere. So there are a couple in the academic buildings. If you're here on Wells College campus, there's one in Zabriskie that I know of. There's probably one in Stratton too. I just don't know of its location. In Zabriskie, it's the 2nd floor. As you're on your way to the grind, that's where it is. And that's how you can help with saving someone's life. So that's all I had for you. It was a brief, an hour and 20-minute talk about the heart and the vasculature and related medical emergencies. Again, this is just an overview to get your toes wet in the topic, and get you a nice little note sheet to study everything from. So I hope this helped, and enjoy the rest of A&P.